Welcome to the webinar, Increasing Awareness and Improving Clinical and Cost Outcomes in Veno-Occlusive Disease. This program is provided by North American Center for Continuing Medical Education and is supported by an educational grant from Jazz Pharmaceuticals. I am Dr. Eric Cannon, Vice President of Pharmacy Benefits with Select Health and Intermountain Healthcare in Salt Lake City, Utah. And also presenting with me today is Dr. Paul Richardson, the R.J. Corman Professor of Medicine, Harvard Medical School in Boston, Massachusetts. And between the two of us will be your presenters today. On this slide, we have the disclosures of both of us. Our goal in speaking to you today is to provide a high-level overview of veno-occlusive disease. And so we'll start with a brief introduction. We'll review risk factors. We'll talk about the benefits and the limitations of traditional and new approaches to the management of VOD. We'll outline potential clinical and cost benefits of early treatment or even prophylactic treatment. And then we'll talk about incorporating the latest clinical evidence and recommendations into how we make decisions within a health plan. So when we talk about veno-occlusive disease, it's a disease that is also commonly known as sinusoidal obstructive syndrome. And throughout the presentation, you may hear one of us use the two terms. They can be used interchangeably, either veno-occlusive disease or sinusoidal obstructive syndrome. VOD is a life-threatening complication that occurs after hematopoietic stem cell transplantation. If you look at the literature, we see a range in the incidence anywhere between 8 and 14%. There was a recent review of the literature that was done, and they reviewed 135 of published reports. And what they found was the mean incidence is 13.7%, so right around that 14% number. Of course, as we talk about incidence and prevalence, that's going to depend somewhat on the portion of patients that exist with a high risk or have been exposed to other predisposing agents. As we review the burden of veno-occlusive disease, we'll look at a retrospective observational trial that was done using real-world data of patients that were undergoing hematopoietic stem cell transplantation. They started with 5,400 patients that were receiving the transplant, and of that, what they found was that there was about a 5.4% incidence of veno-occlusive disease. They further classified it into severe and non-severe. And for severe, they looked at ICD-9 codes for different risk factors. And what they looked at were things like respiratory failure, acute renal failure, dialysis, hypoxia, other things that would indicate that that veno-occlusive disease in that particular patient was severe. And what they found there was that 2.5% of the patients fall into that severe category. So looking at hospital length of stay, what they found was, and this was after they had made adjustments for the type of hospital, the demographics of the population, many of those things that we try and control for in research, and what they found was that the average length of stay for someone that does not have veno-occlusive disease is about 24 days. But those patients that develop veno-occlusive disease jump up slightly, and then when we move into the severe veno-occlusive disease category, we're up almost 31 days. So we're looking at an increase of almost 7 days for those patients that develop severe veno-occlusive disease. Similar to what we would see with the hospital length of stay, the cost follow along at the same trajectory. We see that for those severe patients, the hospital costs are about $141,000, and for those patients that don't develop VOD, the hospital costs ran about $100,000. When we talk about the burden of disease, in my mind, probably the ultimate indicator of burden is mortality. And so the authors also evaluated inpatient mortality, and what they found was for those patients that don't develop veno-occlusive disease as part of the transplantation process, have a risk or have mortality rates less than 1%. For those severe patients, that number approaches 11% or 10.63%. So in summary of my introduction, and as we talk about the socioeconomic burden of veno-occlusive disease, we already know there is a significant burden for those people that are undergoing hematopoietic stem cell transplantation. But if we look at those people that develop veno-occlusive disease, we know they're faced with increased length of stay, and I think we saw data that it was almost 7 days. We know there's increased health-related costs, and the mortality risk is almost 6 times higher compared to those patients that don't develop veno-occlusive disease. That concludes my initial introduction. I'm going to turn the time now over to Dr. Richardson for the clinical part of our presentation today.
Thank you so much, Dr. Cannon. I will discuss the following during my presentation. I'm going to speak specifically to aspects of diagnosis, prognosis, and therapy in terms of hepatic veno-occlusive disease and sinusoidal obstruction syndrome after stem cell transplantation. And in the context of treatment, we'll discuss some of the previous strategies employed to treat hepatic veno-occlusive disease, SOS, and we'll also then talk about new and current approaches to management, including the application of Defibrotide for the treatment of hepatic VOD SOS associated with multi-organ dysfunction. So with that in mind, I'm going to start basically by introducing you to hepatic VOD post-stem cell transplant and its definition. This is also known, as I mentioned, as sinusoidal obstruction syndrome and characterized by hepatomegaly, that's typically painful, jaundice, fluid retention, weight gain, and ascites, and typically onset is within the first 3 to 4 weeks post-transplant with other causes absent. The pathophysiology is complex. It's characterized by primary injury to sinusoidal endothelium, followed then by hepatocellular damage, activation of stellate cells, and this in turn leads to venular microthrombosis, fibrin deposition, marked ischemia, profound fibrogenesis, and this altogether results in portal hypertension, which in turn is followed by hepatorenal syndrome, multi-organ dysfunction that progresses to multi-organ failure and ultimately to death. Now, in terms of the intricacies of sinusoidal injury, this is worth touching upon, just to simply share with you that the unique microvasculature of the liver is particularly vulnerable to toxic injury. And these small microvessels that percolate through the liver architecture are the primary site of injury for hepatic VOD SOS. And what we see is the release of cytokines, expression of adhesion molecules, markers of endothelial stress, activation of heparinase, and other phenomenology that lead to activation and damage to the sinusoidal endothelium, followed by gap formation, fibrin deposition, and narrowing of the sinusoids. And this, in turn, results in the classic venular occlusion that represents very advanced pathophysiologic finding in this syndrome. Now, in terms of risk factors for the disease, it's worth touching on these. Obviously, pre-existing liver disease is well established. So is the use of a second transplant. Allogeneic transplant is clearly associated with greater risk than autologous transplant, and particularly allogeneic transplant used beyond second relapse in a variety of hematologic cancers. Most importantly and most recently, breakthrough agents like gemtuzumab and inotuzumab, which are critical new components of the therapeutic armamentarium against AML and Philadelphia-positive ALL, respectively, have been clearly associated with higher incidences of veno-occlusive disease SOS, both prior to stem cell transplant and indeed afterwards. Now, in terms of conditioning regimens, these include busulfan, cyclophosphamide, and/or melphalan. Abdominal irradiation is clearly established. And I think it's worth mentioning that there are a variety of underlying diseases that may be very important. Now, in children particularly, osteopetrosis and adrenoleukodystrophy, primary hematophagocytic lymphohistiocytosis is also associated with higher rates of veno-occlusive disease SOS, and very importantly, other more common perhaps conditions in adults, such as myelofibrosis, can be associated with higher rates of VOD SOS. Now, interestingly, data on genetic risk factors are an area of active research, and fascinatingly, an association of heparinase gene single nucleotide polymorphisms with VOD after stem cell transplant in children has been identified as an important risk factor, and this is particularly relevant given the activation of heparinase seen in the syndrome. Now, what about the clinical criteria for the diagnosis of VOD? Well, the Seattle criteria are summarized here. So are the Baltimore criteria, which are probably the most sensitive and specific, but typically are hallmarks of more advanced disease. And modified Seattle have been more broadly adopted more recently, particularly in the setting of pediatric practice. Now, all these criteria have high specificity, but relatively low sensitivity. What's particularly exciting has been the new EBMT criteria for VOD SOS in children and adults. And this was recently published by the EBMT in BMT. And I include here a reference from our recent review, which is at the end of this webinar for you, from expert reviews in gastroenterology and hepatology as a resource. But essentially, the new EBMT criteria look at definition in children and adults. And the takeaway message from this is that it addresses both late onset, classical time frame of disease, classical VOD SOS, and particularly important in these criteria, I think, are the new criteria for children, which I do think represent an important advance for us in clinical practice, because obviously they alert you to earlier onset disease in children and some of the characteristics seen, but most importantly also in the adult space there is a real effort to address the issue of late onset VOD as well. Now, when we think about prognosis in VOD, I think probably the most important takeaway is that the presence of multi-organ dysfunction, multi-organ failure is a hallmark of poor prognosis. Rate of rise of bilirubin in patients with icteric VOD is obviously also very, very concerning and ominous if it's rapid. Rate of weight gain in the same context, of course, is also particularly relevant. So in summary, multi-organ failure or multi-organ dysfunction has emerged as the best parameter to date for predicting bad outcome. And when you have advanced multi-organ dysfunction or multi-organ failure, as I like to think of it, the all-cause mortality exceeds 80%. The previous standard of care in this dismal setting was just best supportive care. Now, in an effort to improve our understanding of severity, the EBMT, in the same edition of BMT, published a grading criteria for VOD SOS that represented a consensus opinion between pediatricians and adult hematologists, oncologists specialized in transplants, with the goal of revising this criteria to provide us with a somewhat more useful set of parameters with which to address prognosis. Now, I will stress that the reason for this has been in the past that the presence of multi-organ failure or multi-organ dysfunction has been seen as a vital requirement before embarking on potentially hazardous therapy. With the approval of Defibrotide and improvements in supportive care, I think we're in a much better situation because these new approaches to therapy are characterized typically by a low frequency of treatment-related toxicity. In fact, generally speaking, side effect profiles, particularly Defibrotide, have been highly manageable. And in that context, the ability to intervene earlier has become a reality. And in that same context, the efficacy of this agent has been particularly improved. And we're going to touch on that a bit later in the presentation. But that provides some context to why these new criteria of mild, moderate, severe, and very severe have been developed, and why they're trying to allow or facilitate clinicians to think proactively about intervention and at the same time recognize early features of multi-organ dysfunction to provide clues as to how a patient may or may not do and how important it is to then intervene. Now, with that in mind, when we talk about potential points for intervention in VOD, I summarize on this next slide the potential points for intervention in VOD. Now, on the one hand, there's epidemiologic stratification, which we touched on before, conditioning regimen risk, previous therapies, for example, the use of some of the antibodies like gemtuzumab or inotuzumab that may be associated with higher risk. Then there's a strategy to target cell injury using ursodiol, monitoring drug levels, and supplementing a variety of proteins in the hepatocytes to minimize cell injury. All of these are certainly laudable, but in practical terms, probably only ursodiol has been established as a viable approach. But of course, the real-time PK monitoring of drugs like busulfan obviously can also be helpful. In the context of inflammation, we're beginning to realize that this does have a role, and that whilst inflammation can be abrogated with the use of specific strategies, some are more practical than others. And obviously in the setting of a transplant patient who's exquisitely vulnerable to infection, the use of steroids has to be approached with caution. In the context of microthrombosis, fibrosis, and necrosis, I do want to mention that there are a variety of strategies. We'll go into these in more detail, but some are clearly more practical than others, and clearly some are safer than others. So I think in the management of VOD, the first message is that strategies primarily consist of supportive measures. Heparin TPA was the first thrombolytic approach employed in the management of VOD almost 20 or over 20 years ago. Unfortunately, whilst responses were seen in up to a third of patients, survival was dismal primarily because of the increased risk of life-threatening bleeding. And unfortunately, in this context, it was clear that if you had multi-organ failure in your patient, the risks of catastrophic complications were much higher and outcomes were dismal. So thus, we were left as clinicians with the conundrum that if you had severe disease, TPA heparin was less likely to work and positively challenging in terms of life-threatening side effects. But if you used it earlier, there was still the risk of side effects, and then the overarching question of whether or not you really needed to intervene at all. So with that in mind, it's worth touching on some of the data on TPA with or without heparin and summarizing that for you, and I've done that. And what you can see is, again, responses, but unfortunately a prohibitive rate of potentially life-threatening toxicities. Now, I do want to mention that liver transplant can be beneficial in a small number of patients in which this has been attempted, and so-called peritoneal shunting has also been employed as a supportive measure. But supportive care notwithstanding, it's very important to recognize that a clear rationale for the development of new therapies was urgently needed and has hopefully been met with the development of novel therapeutic approaches to target vascular injury. I simply underpin the hypothesis that underlies this approach and how it could also theoretically be applied to other syndromes associated with transplant toxicities that are underpinned by endothelial damage. I seek to summarize for you the proposed mechanisms of action of defibrotide. And when we first developed the hypothesis back in the mid-90s to deploy this drug in this setting, the hypothesis was simple. We'd made the observation that endothelial injury was fundamental to the process, and therefore what we sought to do was find putative agent that could target endothelial damage without prohibitive toxicity, and at the same time also not protect tumor. Defibrotide was a unique, first-in-class polydispersed oligonucleotide, which had been shown to exert protective effects on the endothelium. And certainly back in the 90s, its understanding of its mechanism of action was very unclear, but we've clearly made tremendous progress since then in better understanding how it may work. And most importantly, clinically, it's been demonstrated repeatedly to be effective. There are thus two involved distinct elements to the way the drug works. It protects endothelial cells, and it restores the thrombotic fibrinolytic balance in a favorable fashion. Defibrotide essentially decreases the influx of inflammatory mediators. This is very important, including ICOM-1 and heparinase, and it activates the fibrinolytic system by upregulating TPA, releasing tissue factor pathway inhibitor and thrombomodulin, and downregulating PI1 tissue factor and VWF. So to summarize, it has this protective effects on endothelium, it restores the thrombofibrinolytic balance, and it decreases inflammation as well as activating fibrinolysis in this context. So it's perhaps no surprise then that when we applied this, somewhat more empirically I would hasten to add, when we first developed the drug in clinical settings, of extremely sick patients with advanced VOD and multi-organ failure, we were struck by high rates of response, survival that exceeded expectations several-fold, and a favorable safety profile. It summarizes some of the pivotal trials that have underpinned the development of defibrotide over the last 15 years or so, with our first experiences in the late 90s, and then through 2000 to 2010, our randomized phase 2 studies, followed then by our pivotal, historically controlled phase 3 trial, which led to its FDA approval. And the message really from this data is a consistent response rate, particularly in the context of advanced multi-organ failure, a survival that far exceeded expectations. And in our pivotal trial of 102 patients with very advanced disease, compared to a rigorously selected blinded control, we were able to demonstrate a significant improvement in complete response rate and a significant improvement in day plus 100 mortality, with a manageable safety profile, as well as no unexpected or unanticipated side effects. And this clinical benefit demonstrated in this trial provided the clear platform for regulatory approval both in the United States and in Europe, supported by the large randomized phase 2 that had been done before the phase 3 in 150 patients, in which again, with advanced multi-organ failure, complete response rates approaching 50% were seen, with day plus 100 survival at around 40%, which again was associated with a favorable toxicity profile. Now, when we look and drill down on the details of these studies, I'm just going to summarize them here, that basically in the phase 3 study, which was the 2005-01 trial that led to the pivotal findings and the FDA approval, essentially we were able to employ this novel historical control methodology to establish the efficacy of the agent. There were 102 patients in the treatment arm. There were 32 patients in the rigorously selected historical control, and the phase 3 results demonstrated a convincing improvement in survival and complete response rate at day 100. Complete response was very rigorous. I should stress that in, for example, the trials published on TPA heparin and other approaches to therapy and VOD, typically response was classified as a 50% reduction in bilirubin. Here in our pivotal trials, we were quite rigorous about the definition of CR, and this was an approach we used in all of the defibrotide trials, such that that CR standard has now become the new gold standard for effective therapies in the treatment of VOD-SOS. And as we move on to the Kaplan-Meiers that we've published on the phase 3 trials, you can see by log rank testing a statistically significant improvement in the defibrotide treatment control group, defibrotide treatment group compared to historical controls, and that graphically shows very nicely. Now, one of the challenges with a historical control is the historical control representative of what's really going on? And then I seek to show you that by demonstrating how the historical control on the left performed compared to a variety of comprehensive meta-analyses of survivorship in severe VOD characterized by multi-organ failure. And as you can see, the day plus 100 mortality rate was clearly comparable to that observed in previous trials. And this is, I think, better illustrated on the next slide, where we show how the historical control performs compared to the published literature as well, again validating, we believe, its validity going forward. And so in summary, defibrotide improved complete response rate and survival using this unique historical control methodology, and at the same time was generally well tolerated, with toxicities observed that were similar to those observed in previous studies. Now, one very important trial to emphasize is the EBMT phase 3 study for defibrotide, in which the prevention of VOD was tested in exquisitely high-risk patients, and specifically in a pediatric population. This pivotal trial was published in The Lancet a few years ago, and basically 356 eligible patients either received prophylaxis or observed as a control group with crossover allowed should they develop VOD. And I summarize the study design in the next slide. And as you can see, critically, if you were in the control arm as a high-risk child, if you develop VOD, you could cross over and receive defibrotide. This is important as one interprets survival data. Now, in terms of phase 3 prevention results, there was a significant reduction in the incidence of VOD in children in favor of Defibrotide demonstrated in this prospective randomized phase 3 trial. Fascinatingly, there was also a significant reduction in the incidence of severity of GVHD in this prospective trial that was was a pre-planned secondary endpoint, and to our, I would say, satisfaction. It was very impressive to see this. Now, why, you might ask, did we look at this? Well, we looked at it because in the treatment trials we had seen a lower rate of GVHD than we were expecting in such a high-risk population where GVHD has typically been associated with as a major component of mortality in VOD SOS, and this just wasn't being seen in the Defibrotide trials. And given the mechanism of action of Defibrotide, we speculated there was an anti-inflammatory effect. And so in this context, it was particularly gratifying to see this borne out in a phase 3 prospective randomized setting. Now, beyond that, I would stress that we've then subsequently had a very large treatment IND experience for patients with hepatic veno-occlusive disease that has been comprehensively analyzed and now has been presented and most recently published. This was a remarkable effort. It was a treatment IND launched in the United States. And it was done as a key bridge to the FDA approval of Defibrotide in order to provide access to the drug. The efficacy and endpoints are summarized on slide 29. Dosing was classical, and this study incorporated over 640 patients and is therefore one of the largest of its kind. And what I want to simply emphasize is it included both transplant and non-transplant patients, although obviously the vast majority were allogeneic transplant recipients, and the primary disease was typically acute leukemia. Now, very importantly, in terms of the criteria employed, we initially strictly stuck to Baltimore plus multi-organ failure. We then had modified Seattle where permitted as improving safety data emerged with Defibrotide, and particularly with the success of the pivotal phase 3. By protocol amendment, adjustments were made to the study to allow greater access to the treatment IND. What was very important was that the summary of adverse events are summarized here on the 2 and were very much in line with what we had seen before, with low rates of toxicity and very manageable side effects. The adverse events that were of interest, and obviously in any setting of a profoundly thrombocytopenic coagulopathic patient, hemorrhage remains a major concern, but these all proved manageable, generally speaking. And certain side effects associated with Defibrotide use, such as hypotension, are worth mentioning simply because they usually are manageable with holding drug, appropriate supportive care, and then reintroducing therapy accordingly when the patient is more stable. Typically, hypotension occurs in the setting of other concomitant issues occurring, such as, for example, sepsis. Now, what was the survival in this large treatment IND experience? Well, what was particularly gratifying to us was to see a very consistent signal, both in terms of survival and complete response rate in this trial. And it's important to mention that because typically in the setting of treatment INDs after approval is underway, these kinds of expanded access programs usually see a deterioration in quality of results overall outside of the setting of pivotal randomized controlled trials or similarly controlled phase 3 studies. And in this setting we saw quite the opposite. We saw a highly consistent signal, particularly in the children. We also saw very consistent results in the adults. And what was particularly interesting in those patients who did not undergo transplant yet had severe VOD from, for example, triggers such as triple or quadruple alkylator therapy and the use of some of the more VOD-genic new antibodies, we saw very consistently high response rates as well as excellent tolerability. Now, if one drills down into the allograft and autograft subgroups, again see a very consistent signal in terms of survival for both allo and auto. And what we do also see is that if you use the drug in the absence of multi-organ failure, in other words, advanced MOD, you see dramatic improvements in outcome. Now, recognizing that this isn't a randomized comparison, but represents a prospective phase 2 experience with subset analyses, so with the cautions to that, but nonetheless, the signal appears very consistent and very much aligned with experiences previously in the United States as well as elsewhere and in Europe. So in conclusion, this particular treatment IND provided the largest prospective evaluation of Defibrotide to date in VOD, excellent day 100 survival, favorable tolerability, and obviously future directions include taking this broadly into the prophylactic setting, and current randomized trials are now underway, and we would also put in a strong word for earlier treatment, given that we've clearly seen this to be better in this setting. Now, to support that position, we're including at the end of this webinar a very recently published manuscript in the British Journal of Haematology from July of this year to further provide you with information in that regard. Now, in terms of other future directions for improved management of VOD SOS, I just want to mention the point about combination studies with the use of methylprednisolone, N-acetylcysteine, potentially antithrombin 3, and other endothelial targeting agents. Certainly, methylprednisolone combined with Defibrotide has been tested clinically and been shown to be particularly helpful to patients with marked transaminitis, and especially in those patients who may be experiencing veno-occlusive disease SOS in the context of immuno-oncologic therapy use, such as checkpoint inhibitors, antibodies, and otherwise. What I think is also very important is the prophylactic space in high-risk allogeneic transplant, high-risk autologous transplant as well. And finally, in terms of the specific high-risk groups, I do want to mention the sirolimus-exposed patients who appear to be particularly vulnerable to this, mismatched unrelated allogeneic transplant who also appear to be vulnerable to VOD SOS, and I've already mentioned gemtuzumab and inotuzumab use as another clear high-risk group. Then a final question is this a very promising new agent that could be adjunctive in GVHD? And we will see. Trials are planned or underway in this regard. And finally, thrombotic microangiopathy, a real challenge in the treatment of patients with hematologic malignancies, particularly in transplant, but also arguably in other settings now with immuno-oncologics. Will Defibrotide have a role? And prospective trials are planned in this regard. So to summarize, VOD SOS is a potentially life-threatening complication of transplant. It can also be seen in the non-transplant setting and can be devastating as well. Mortality with advanced multi-organ dysfunction or multi-organ failure can be as high as 80% or more. Diagnosis is classically clinical, and the current management primarily revolves about optimal supportive care, but with the advent and the approval of Defibrotide in the last 2 years, we have a novel agent which is now available for patients to reverse the syndrome with a highly acceptable tolerability profile given the exquisite illness that's seen in such patients and the high risk of these patients from toxicity concerns, and at the same time a very consistent level of efficacy seen both in terms of complete response and survival. In terms of future directions, obviously, prophylaxis is key. And I want to conclude by just emphasizing the remarkable partnership that's allowed for the development of Defibrotide involving our pharma partners, the incredible support of the FDA and our regulatory organizations, as well as, of course, our academic partners. So I want to conclude by thanking you very much for your kind attention. Thank you very much indeed.
Okay, moving into the managed care presentation, and thank you, Dr. Richardson, for that overview of the clinical information that we have. Before we dive deep into formulary issues and even some of the pharmacoeconomic issues, I thought it'd be good for us to discuss the role of managed care, discuss briefly the dimensions of formulary, and really talk about some of the things that we're focused on from a managed care standpoint as we make evaluations of drugs that fall into categories such as this. As we start and look at formulary, we are very focused on the efficacy of the products and the safety. So those clinical items, and I think, why are we focused on those? That's because of the patient. So we probably have the patient in two spots on this slide. On the far right, we have the things like adherence and then the administrative burden for a particular patient. In the middle, we've got the economics, the treatment costs, and then what is appropriate utilization. So when we talk about the role of managed care, we know that managed care makes many contributions to optimal patient care. They're done through these three things that we've got on this slide. The first being providing accessible and affordable therapies through formulary review and management. The second is aiding physicians in the understanding and the implications of the available products. We find that a large portion of what we do on a daily basis is provide education at many different levels. And then we also spend a lot of time assisting in the process for development and management of guidelines and care plans. When we talk about a formulary, we are starting to see many shifts within the industry. If you look at today's formularies, they're driven by class of drug. We many times focus on tiered co-payments or co-insurance. We look at step therapy. And then we try and manage those high-cost drugs by indication many times through the process of prior authorization. When we look at where we are today and where we would like to be in the future, I think it's critical that as we all develop formularies, we think about these things, that we really want to be in a value-based mode. We want to pay for those things that work, and we want to interact and integrate with accountable care organizations, take that information directly to the front line. Personalized medicine is going to play a larger and larger role as we go forward, and we will talk briefly about some stratification that I think plays into guidelines a little later here in my presentation. We're also seeing now many disease states where we have companion diagnostics that help guide treatment and I think provide clear direction for us many times on what will work and many times what won't work. On this slide for you, what we've done is summarize the medications that are used in veno-occlusive disease. And you can see we've broken it down into two subsets, so prevention and treatment. We've got Defibrotide recommended in the prevention category. It's also recommended in the treatment category. But we've got a lot of things now that are not recommended. Everything from heparin to prostaglandin E1 on the prevention side, and N-acetylcysteine on the treatment side. Methylprednisolone could be considered. I think the other piece that's really important on the treatment side is this judicious clinical care, really maintaining the appropriate fluid balance. And then early discussions with specialists, those that really understand the disease and have experience with it. Defibrotide. So let's look at Defibrotide. It was listed on both the prevention and the treatment side of things on our summary slide. The recommended dosage is weight-based. It's given as part of a 2-hour IV infusion, and it's done every 6 hours for a minimum of 21 days. When the medical letter reviewed this, they had a published cost of about $156,000 for 21 days of treatment. When we look at the open label studies for veno-occlusive disease following hematopoietic stem cell transplantation, we see that the survival rate was significantly improved. In one trial, 38% survival rate versus 25% with some matched historical controls. In another trial, the survival rate was 44%. So moving on, and let's talk a little bit about the cost effectiveness of Defibrotide. So compared with historical controls, what was seen was a demonstration of a 23% improvement in 100-day survival following stem cell transplantation in those patients with severe veno-occlusive disease. When we look at the budget impact model that was developed by the authors as part of this trial, what they found was about 2.3% of adults and 4.2% of children would develop severe veno-occlusive disease following stem cell transplantation. When they ran that through their incremental cost effectiveness models, what they found was that the ICER for Defibrotide was about $47,700. that places it in the cost-effective category. And you can see here we've got the probability of it, 88% likelihood at a $100,000 threshold. The authors further took this and they really looked at their economic model from the standpoint of annual costs in a transplant center. And so what they found was that for a 100-patient cohort, the annual costs for those patients that don't get Defibrotide is just over $10 million, $10,030,000. And if you look at those adult patients that do get Defibrotide, the cost is $10,361,000. So on a $10 million budget, not much difference between the two. When we talk about pediatrics, we're talking about $18.7 million, approaching $18.8, and then $18.8 million for those patients or those pediatric patients that also got Defibrotide. Moving on, let's talk about the cost effectiveness of Defibrotide in prophylaxis. And so in one trial, what they did was they did an evaluation of 438 pediatric patients that had been identified as having undergone hematopoietic stem cell transplantation. And what they found was that there were 138 were at risk of veno-occlusive disease. What they found in the population that the total incidence was about 7.4%. When they calculated the cost for prophylactic Defibrotide, what they found was that if they'd used it in the 138 patients they identified, costs would have been almost 6 times higher than the incremental costs for patients that developed veno-occlusive disease without getting the prophylactic treatment. In this trial, they came to the conclusion that prophylaxis is not cost-effective with Defibrotide. Now, when we look at the trial and we dig into the details, there are some limitations to this. And the cost analysis included all patients undergoing hematopoietic stem cell transplantation, and not just those patients at risk of developing severe veno-occlusive disease. And I think as we talk about stratification of who's the appropriate patient, really looking at those at risk of developing severe veno-occlusive disease is going to be critical. So what are the recommendations? And this slide's taken from the British guidelines around veno-occlusive disease, and you can see in pediatrics what they've recommended as far as prophylaxis and for whom they've recommended it. And I think they've done a good job providing us with a list of items that we can track and we can work against. They've assigned a level of evidence of 1A for the use of prophylaxis in the pediatric patients, and they've done the same thing with the adults. You can see that the lists are pretty much identical as it relates to the different risk factors that should be considered when thinking about prophylaxis. So now let's talk a little bit about treatment stratification. And this slide is based on recommendations from a physician out of Spain that frequently treats veno-occlusive disease. And he broke it down into 3 categories. Preventive measures, those that you monitor, and those that for whom you would consider Defibrotide. And he really starts with saying, our initial focus should be on prevention. And so he mentions resolving reversible risk factors first. So if they have acute hepatitis, making sure we treat that. If there's iron overload, making sure that that's treated. On those patients that have irreversible risk factors, so this is their second transplant, they've had previous liver disease, or they've undergone treatment with several different agents, that places them in that irreversible risk factor category, and those are patients for whom we should consider prophylaxis. Once we have someone going through the process, it's critical that we monitor for veno-occlusive disease and then diagnose when appropriate and start treatment immediately. And then in those severe patients, and there's a list of things to monitor for, Defibrotide is definitely recommended. So when we talk about monitoring, and I think on the previous slide we had talked about monitoring and we had talked about using Defibrotide in those patients that are severe. I'm a very visual person, and so I find tables and graphs and things very helpful, and I think from the standpoint of monitoring, I find the items listed here very useful. What the authors have done is break this down and give us basically 5 clinical categories of data that we could be looking at, and then based on what those numbers are, so if you're less than 3 times normal on the liver function test, you'd fall into the mild category. If you're greater than 5 times normal, that'd put you in the severe category. When we talk about care management and managing our patients and monitoring, I think as we move more and more into accountable care or even shared risk models, we're utilizing care managers and other ancillary providers or support staff to improve the outcomes of our patients. Having tables and graphs and models like this, I think, are very critical in optimizing the treatment for our patients. So, in conclusion, veno-occlusive disease is associated with significant costs and mortality. I think we saw that in the first set of slides I presented today. We know that opportunities exist for risk and treatment stratification. There are clearly defined lists of risk factors. There's clearly defined items that we can monitor our patients to evaluate when they may need treatment. We know Defibrotide provides a cost-effective opportunity for patients in both the treatment and the prophylaxis categories. And then as we work all the way through this, there's multiple opportunities that exist for managed care to help optimize treatment and improve outcomes for our patients. That concludes my presentation for today. Thank you very much for attending this webinar. We'll now open the question and answer session.
Good afternoon, and thank you for joining us for today's webinar. My name is Dr. Eric Cannon, and I will be answering your questions today along with my colleagues, Dr. Ho and Dr. Richardson. I'm excited today to have 2 such incredibly knowledgeable people with us as we start to take questions from our audience. As a reminder, if you would like to ask a question, please type your question into the question box. Our first question comes to us from our audience, and it's this. And Dr. Ho and Dr. Richardson, I'll let you kind of defer between each other as you answer this. But the question is this: is there data concerning survival past 100 days using Defibrotide?
Eric, thank you very much, and thank you very much to the audience for their participation, and that's an excellent question. If I may, I'll take the first part of it, but I'd love Vincent to comment more because we have some of our own institutional data which I think sheds a very nice light on this question. In terms of long-term outcomes, we've been very pleased that beyond day plus 100, we do see clinical benefit that is prolonged and spans many years from a variety of the trials in terms of long-term follow-up. And we looked in the control trial, the phase 3 pivotal trial,
beyond day +100 out to day 200. The analysis basically compared to the historical controls was not surprisingly favorable, but it was thought to be important to be a little conservative in that assertion, as the primary endpoint in the trial was day +100. So for that reason, it's something which hasn't been sort of widely publicized, but beyond day 100, we did see long-term survival in the absence of provocative any long-term toxicities, certainly. And what's really, I think, important to share with everyone is that in the majority of patients, we really have not seen recrudescence of VOD later on or at a later stage. Having said that, obviously, depending on the extent of liver damage, there can, in a small subset of patients, in my experience, be some sensitivities in terms of liver function that one has to be aware of. But long-term outcomes in the clinical trial certainly have been generally favorable. And the most important observation has been there hasn't been evidence of any increased rate of primary disease relapse, such as leukemia, for example. Those would be our observations from the actual larger trials. Vince, do you want to comment more?
Yeah, thank you, Paul. So I do want to chime in just to sort of let the audience know. We did complete a very large retrospective analysis of all the VOD patients that have been treated here at the Dana-Farber over the last decade and a half. And this has not been published yet, but we did look at the patients who survived to 100 days with their VOD and compared how these patients did to patients who didn't have VOD. And in our analysis, we had 93 patients who survived to day 100 with VOD, and we followed them out, and we've actually found that their survival at 5 years was actually quite encouraging. The survival at 5 years was 48% in these 93 patients who had VOD and lived beyond 100 days. Compared to the patients who didn't have VOD, the survival was 55%. So it's a difference of about 7% at 5 years in terms of survival. And importantly, the relapse rate of their leukemia was not different, and the GVH rates in these patients were not different, after 100 days. So it looks like there is some, slight impact of the VOD on survival after 100 days, but that impact is fairly small. And there are many long-term survivors after 100 days.
And Vince, it's important to note these were patients treated with defibrotide, obviously.
Yes, most of them were, not all of them, because our database spans a long period of time.
Right. So we'll be looking deeper at that to analyze those who didn't get defibrotide versus those who did, and obviously that may change that analysis as well. But just important to share with the audience that what we have seen as a signal in the studies is actually a reduced rate of GVHD. We've seen that in the therapeutic studies, and that was actually validated by the prospective randomized trial by the EBMT in children, in almost 400 children, randomized 200 per arm. And essentially, in that trial led by Selim Korbachoglu and published in The Lancet a few years ago now, there was a significant reduction in GVHD rate in favor of those children treated with defibrotide, as well as the study meeting its primary endpoint of a reduction in VOD incidence.
Right, and for that reason, I think Jazz is actually planning to do a GVH prevention study.
Quite, especially given the mechanistic value, which seems to be centered around the fact that heparinase is obviously a prime target in GVHD and is something that is favorably modulated by defibrotide. Specifically, defibrotide downregulates cell surface expression of heparinase, and that's seen as a potentially important clinical benefit, or translating, I should say, into potentially important clinical benefit.
Great, thank you. We've had another question come in from our audience, and they're asking, how is severe VOD best characterized? I know multi-organ failure is part of that, but, when you classify someone as having severe VOD, what are you really looking at? What are you really seeing with those patients?
Well, I would say, Eric, that's a fabulous question, and thank you. And I'd love Vincent to chime in on this as well. But I would start by saying multi-organ failure is clearly the defining event that, above all, predicts the worst outcome in patients with VOD. I think the challenge is that we want to get in sooner because we have clear data that earlier intervention with effective therapy, specifically defibrotide, actually improves outcome. And obviously that was in the presentation, but was published in the British Journal of Haematology just a month or two ago, where we showed in the expanded access program that this clearly was the case. So we tend to look for parameters that might sort of predict for severity, but at the same time don't sort of hold us back from initiating treatment promptly. And in that regard, I think multi-organ dysfunction is a very useful thing to think about, because that's not as advanced as multi-organ failure, certainly in my mind, but reflects the fact that you're seeing hepatorenal syndrome, you're seeing fluid retention, you're seeing a minimal bump in creatinine, you may see an oxygen requirement, and therefore you can act upon those kinds of clinical parameters. Other clinical parameters include the rate of rise of bilirubin, if the patient's icteric, the rate of weight gain. Those are all useful clues, and especially the presence of a rapid onset of right upper quadrant pain relatively early in the transplant course. But I do think multi-organ dysfunction, generally speaking, recognizing that that can be a spectrum, certainly to my mind is clinically one of the more useful aspects of assessing severity. But I'd love Vincent to comment more, if that's okay, Eric.
Yeah, no, I totally agree with Paul. I think multi-organ dysfunction is clearly the defining characteristic of severe VOD. I should also add that the timing of the VOD probably matters as well. Patients who get VOD very soon after their conditioning will tend to do worse than patients who get VOD a month or two later. So it's the rate of rise of bilirubin, the time from transplant, and the rate of weight gain as also important factors. We've also done some recent studies here within our own database looking at early parameters that would predict development of VOD in the week before the actual clinical manifestations. And we also found that the sudden rises in tacrolimus level, for example, tend to predict sort of onset of VOD, and that's something that we're hopefully going to be publishing in the next year.
Great, thank you.
Sorry, Eric, if I may add just one point to that, though, I would just say that that's a super comment from Vincent, because I do think that in terms of severity, some of this later onset VOD mustn't be underestimated, because the one thing you have to be careful with the late onset VOD is that it can be manifest with hepatorenal features, particularly with portal hypertension. And that's the only one point I wanted to add, Eric, that even though it may be later onset, that can still be associated with high rates of MOD.
No, great. I think those are fantastic points. I think we've got time for one more question, and I think where many of our audience are focused on the managed care side. In the literature, there's a lot of discussion about stratification of patients and then the potential use of Defibrotide prophylactically. Can either of you talk, how you see the role of stratification? Where you see, we know Defibrotide is not approved by the FDA for prophylaxis, but, where do you see all of that falling out?
That's a super question. If I may, Eric, I'd suggest, if you don't mind, Vince and I both contribute to that. Vincent, do you want to go first on that one?
Yeah, no, I think it's not clearly defined what the role of Defibrotide is in terms of prophylaxis. As you know, there's a study going on right now, testing Defibrotide as prophylaxis in patients who are deemed to have very high risk of developing VOD after their transplant, and that study includes both adults and pediatric patients. And I think there are about more than 20 countries doing that study. But as of today, Defibrotide is not FDA approved for use as a prophylaxis in patients who are deemed to have high risk of VOD. So at our center, we have not been doing that, but our goal is in these patients is to watch them so closely that as soon as they develop any parameters to suggest they're developing it, that we try to start the Defibrotide as early as possible.
Yeah, I completely agree, and I think, Eric, the last comment to that for your folks on the call would be simply that we do see this as a critical space, because there is no question that there are high-risk patients. The more allogeneic the transplant, as it were, the more likely the risk. That means essentially mismatched or at a very high degree of immunogenicity associated with its use. Those patients are particularly high risk. Patients with underlying liver disease, be it primarily from the disease itself, such as myelofibrosis or some of the pediatric conditions characterized by pathology in the liver, or in fact from prior liver injury. And another very important area is the drugs that the patients have been exposed to, in particular drugs like Mylotarg and inotuzumab, which is, of course, recently approved for Philadelphia-positive ALL. And these are patients who are exquisitely high risk of Veno-Occlusive disease, SOS. And those patients, I agree entirely with Vincent, according to the current approval, early intervention for these folks really matters and clearly carries benefit. But obviously, prophylaxis, hopefully, if the studies are favorable, will be supported. It is worth mentioning once more the positive trial from the Europeans and the EBMT specifically in children. That was a remarkable study confirming the safety of the drug and at the same time showing efficacy in reducing VOD incidence as well as GVHD. Because kids were allowed to cross over, obviously, if they developed VOD, there was no survival difference in that trial. But in fairness, that is no surprise, and it showed an ethically well-balanced trial because as soon as the children got VOD, they were treated. But if you looked at other parameters like ICU stay and multi-organ failure, those rates were significantly lower in the children who got prophylactic therapy, or other prophylaxis. So I think the future is looking quite promising for Defibrotide as a preventative strategy.
Great. No, thank you. And a big thank you to Drs. Richardson and Ho for joining us today to take the questions from our audience. That was our final question for today. To be eligible for continuing education credit for today's activity, log on to www.naccme.com, successfully complete the 10-question post-test and evaluation form, and immediately print your documentation of credit. This concludes today's session. Thank you again for joining us.